Hello, everyone, and welcome. I am Farah Douglas, President and CEO of the Liver Health Foundation. Tonight's webinar is about viral hepatitis. Viral hepatitis is inflammation of the liver caused by an infection with one of the 5 hepatitis viruses. Untreated viral hepatitis can lead to serious liver problems, such as scarring of the liver or even liver cancer. Even if the infected person does not have or show any symptoms, they may spread viral hepatitis unknowingly. Getting tested is the only way to know for sure if someone has viral hepatitis or not. In tonight's webinar, we will learn how one becomes infected with one of these viruses, the symptoms they have, available treatments, and the long-term impact of viral hepatitis on one's liver and general health. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, portions of Arizona, and Northern California. In tonight's webinar, Dr. Robert Gish will offer a comprehensive review of viral hepatitis through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Robert Gish, Dr. Edward Mena, and Dr. Sean Chandena. During the roundtable discussion, our experts will talk about their own experiences in working with viral hepatitis patients and their research on this subject. If you have any questions, please use Q&A or chat function, and our experts will try to respond to your question. Please remember, information given by our experts is not a substitute for advice given by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical centers, pharmaceutical companies, or treatments. This program has been made possible by an educational grant from GSK Pharmaceuticals. We thank GSK for their support. It is my honor to welcome back Dr. Robert Gish, who has generously agreed to be the presenter for tonight's program. Dr. Gish is an adjunct professor of medicine at the University of Nevada School of Medicine in Las Vegas and in Reno, an adjunct professor of pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences at UCSD, professor of medicine at Loma Linda University, as well as a staff physician in Loma Linda University's liver transplant clinic in Las Vegas. He is the medical director of the Hepatitis B Foundation in Doylestown, Pennsylvania. After attending pharmacy school at the University of Kansas, Dr. Gish obtained his medical degree from the University of Kansas Medical School in Kansas City. He then completed a 3-year internal medicine residency at the University of California, San Diego, and a 4-year gastroenterology and hepatology fellowship at the University of California, Los Angeles, which included transplant medicine. Dr. Gish is a fellow of the American Association for the Study of Liver Disease, the American Society of Transplantation, and the American College of Physicians. He has co-authored a public health policy for liver health in Vietnam, focusing on HBV, and is also assisting with the development of viral hepatitis healthcare policies in Georgia, Armenia, and the Philippines. He was a major early contributor to decipherment methods for the detection of hepatitis B and C virus and characterizing its epidemiology to the genotypic classification strategies and methods now in use worldwide. He has published more than 700 original articles, review articles, abstracts, and book chapters. Dr. Gish is a member of the Liver Health Foundation Medical Advisory Council. Dr. Kish, welcome. We are excited to have you with us. Thank you for your support and participation. We are ready for your presentation.
All right. Thanks, Farah. Thanks for putting this together and the wonderful Liver Health Foundation. Happy holidays to everybody. Sean, thanks for joining me. Edward, you're fantastic to work with. A great service to the community. I'm going to get my ABC slides up, which should be on the screen. And are we in the full screen mode? Lori, is it everything okay?
Looks good.
Okay, fantastic. So the title of this is that every patient and every provider should know their ABCs, but of course we have A, B, C, D, and E in the mix. So I'm going to cover the entire alphabet, but emphasize what everybody needs to know and what they should be doing in their practice every day, as well as what patients should be talking to their providers about. And let me just figure out how to do the page forward. I'd encourage you to go to my website and sign up for the newsletter. That's super important. There's lots of resources on the website. Now I have podcasts and I capture pretty much every lecture that I give. Hopefully this is being recorded. All right, here's the alphabet soup here. We have A, B, C, D at the top. And over on the far right side, hopefully there's E showing up on your screen. I had to move the screen share over a little bit. So A and E are very, very similar because these are from fecal soiled water and are typically acute. Hepatitis A is never chronic, and hepatitis E is chronic only in very rare settings. Hepatitis E, of course, A is vaccine preventable. Hepatitis E, the only place that there is a vaccine commercially available is in China, although there is some export of that hepatitis E vaccine into the Indian subcontinent. Bangladesh, Afghanistan, some of these other countries, such as India, hepatitis E is much, much more common. B is for bad, C is for chronic, and D is for deadly. Hepatitis B, C, and D are transmitted by intimate exposure. That requires typically some type of blood or body fluid contaminated by blood sharing. And of course, B, C, and D can result in chronic infection. B is vaccine preventable. We're going to get into this a little bit later. I'm making this intro a little bit short. And D is vaccine preventable by giving a vaccine for hepatitis B because Delta piggybacks on B. And of course, C is for chronic, but C is also for curable. But C, there's no vaccine available. So everybody should know their A, B, C, Ds, and Es. And we'll talk about this in some more detail. This is just a really nice intro. So what's been happening, unfortunately, and what we're projecting is this upward curve of B and C infection. And a lot of this has to do with the high-risk behavior that people have sharing needles. And that's one of the big problems in the United States, but it's a big problem worldwide. We have a decline projected in tuberculosis, HIV, and malaria. We have a cure for C, but it's really difficult to access in many countries because governments have decided not to fund it, such as the United States, where we have a lot of obstructions for hepatitis C testing and treatment access. Chronic hepatitis B is also a problem, but this is number of deaths on this curve, so just keep this in mind. Hepatitis B is maturing worldwide, where people in their 40s, 50s, and 60s developing cirrhosis and cancer. Less than 5% of people who have hepatitis B are on treatment because of very complicated guidelines. And they're really not focusing on B as an infectious disease. Our academic colleagues focus on B as a liver disease, and we're going to get back to that message. I always like to start off with the difference between liver enzymes and liver function tests. Providers are very confused about this. I would say 80% of the liver doctors that I know call all these tests LFTs, but that's wrong. Liver enzymes are AST, ALT, alkaline phosphatase, and GGT. And liver function tests are bilirubin, albumin, and this clotting test called INR. So if your provider is telling you that your LFTs are abnormal, you should ask them, do you mean enzymes or do you mean function? Because if enzymes are high, you have lots of time. If function tests are going bad, then it's time to be talking about transplant or some urgent intervention. People who have chronically increased liver enzymes, of course, need hepatitis C and B testing. There's a big mistake by lots of providers. I just see hepatitis A IgM being done on hundreds and hundreds of patients. It's a nearly worthless test unless you have really high liver enzymes. So B surface antigen, but B surface antigen should be part of what's called a triple panel. That should include core antibody and surface antibody. We'll get back to that. And hepatitis C antibody test, if positive, needs to be linked to hepatitis C RNA. Of course, fatty liver, that's a whole nother discussion, which our wonderful organization, I'm sure, will cover this next year. Quick issue on hepatitis A. There was a marked uptick, especially in San Diego around 2016 to 2017. This had to do with homeless people and a lot of fecal contamination of different surfaces. Over 500 people were hospitalized, and I think there were over 20 deaths or transplants due to hepatitis A, acute hepatitis A, because again, A is never chronic. It can be a little prolonged in terms of enzymes and liver function, but hepatitis A is vaccine preventable. So anybody I see with any type of liver disease gets a hepatitis A total antibody, not IgM. And if the hepatitis A total antibody is negative, they get vaccinated. That's across the board, every single patient I see in my practice. Super important. This has to do with risk behavior for hepatitis A, what goes on in this, which is injection drug use, but really it's more all this contact with people, contact with spoiled surfaces in different areas. So there are explanations by risk behavior. This has to do with hepatitis A infection in people with chronic liver disease. They have a very, very high mortality rate. This is an Italian study, but this has been carried forward in other research. This now is very important that we switch gears. Hang on just 1 second. I'm trying to get this screen to change. Sorry. This just is a map about where hepatitis A and B are endemic. They tend to follow each other, although there's more hepatitis A, as you can see, in Central and South America and Eastern Europe. One more. Now we're going to talk about hepatitis B. This is an extremely infectious disease. Over 2 billion people have been exposed to hepatitis B, and that test is something called core antibody. If a core antibody test is positive in a patient, you have to believe that test, and that means they've been exposed and they still have some hepatitis B somewhere in their body. Worldwide, 252 million people are surface antigen positive, and there's about 2.4 million people in the United States. 2 people are dying every minute from hepatitis B, and that has not changed in the last 25 years. We've had great, very effective therapy that can cut cancer risk by 70% and can cut the risk of dying or cirrhosis or a liver transplant by 95%. But we've had very complicated guidelines, and that has been a huge barrier to access. The new move, and this has been really carried forward by the Chinese guidelines and WHO guidelines, is to treat everybody who is DNA positive. And that's the only way we're going to get to elimination, decrease infectivity, a variety of these other endpoints that we're going to talk about. It's not just about cirrhosis and liver cancer. Liver doctors are so wrapped up in the liver, and they keep forgetting about the patient. Even though hepatitis B is not curable, it's suppressible and controllable. And 95% of people on what we call nuke therapy, oral therapy for hepatitis B, are going to be suppressed, where the DNA, the viral load in the blood, is down undetectable. It's not zero, just means undetectable, but there's still hepatitis B, of course, left in the liver. Again, hepatitis B is vaccine preventable, but you only give the vaccine to people who are triple panel negative. More an interpretation, surface antigen is positive. That means infection with hepatitis B, an active infection. Everybody with B needs to be checked for delta with an antibody. And I've been doing for over a decade quantitative surface antigen. I think this should be standard of care. We have hundreds of manuscripts that show the utility of surface antigen, but sometimes liver doctors are just slow to respond, slow to absorb new information. Core antibody equals exposure. That means there's persistent virus in the liver. If somebody has core, they need to be considered for occult hepatitis B reactivation and never should be vaccinated. This test has a false positive rate, the chance of being wrong, 1 in 500 tests. Surface antibody only means vaccine-induced immunity if the core antibody test is negative. If both surface antibody and core antibody are positive, that means immune control, much lower chance of reactivation. There is no healthy form of hepatitis B. We don't use the word healthy carrier. We don't use the word natural immunity. We don't use the word immune tolerant. Those terms are all out of date, and we need to move to 2024 and now 2025. I'm going to be very brief here. If anybody has hepatitis B, they need a variety of other tests. You should talk to your provider about these other tests. And we already mentioned Delta testing. I'm not going to go over this whole table, but this just summarized what we just talked about how you interpret the different hepatitis B serology. And of course, these slides are shareable, should be on the website. And our team here can email those to anybody who wishes to look at these. So hepatitis B, if you get it as a baby, early childhood, chronicity rate's 95%. That means carrying the surface antigen high. But if you get hepatitis B as an adult, the chance of chronic carriage of surface antigen is about 5%. But once a person is surface antigen positive for more than 6 months, that's called chronic disease. And there's this E antigen and E antibody status, which have to do with viral variants. They're part of the workup, but they're a little out of date. They don't really relate to how we currently manage patients. The level of hepatitis B DNA is super important. So once somebody is surface antigen positive, we send off this DNA blood test, and it helps decide what that person's prognosis is, the chance of going on to cancer, going on to cirrhosis with end-stage liver disease, needing a transplant, but it also indicates infectivity. But surface antigen quantification also relates to infectivity, and that's why these two tests are really, really good partners. That high DNA relates to cancer risk, and if the DNA is positive, in my opinion, standard of care is just to put everybody on treatment. And again, that comes forth from some very, very well-written international guidelines. The AASLD's guidelines are 10 years out of date. They're being rewritten this year, but even when the new guidelines come out, they're going to be very limited. So don't just look to the American guidelines, really got to look internationally to cover all the issues. This is some of the list of reasons to treat everybody who's DNA positive. So it has to do with quality of life, infectivity, stigma. Our risk-based testing, of course, has failed. We're going to test everybody for triple panel, and we're going to treat everybody who's DNA positive. This is super important. And we treat typically with entecavir, tenofovir TDF, tenofovir TAF, but pegylated interferon is almost never used in the US and Europe, although in Asia, specifically in China, interferon's used a lot. And there's lots of different reasons behind that, but pegylated interferon will be back in play, in my opinion, as new therapies come forward. You have to remember there's 65 drugs in development for hepatitis B, and we will have a high rate of functional cure, I think, in the next 3 to 5 years. Back to the goal of treatment, every patient who's DNA positive, we want DNA negative. If they're DNA negative, there is a chance they will lose surface antigen, even with our current therapies. We want to make the liver better, but we want to reduce stigma, infectivity. We want to make people feel better. And when you put them on treatment, they stay in care. If you tell a patient, oh, you don't qualify for treatment, you don't meet the guidelines, 40% of those patients disappear. They don't come back for any more care. The doctor said I was okay, didn't need treatment. Why should I go back? There's a huge dropout rate just by telling people they don't fit the treatment criteria. So 5-line guideline for hepatitis B, everybody gets a triple panel. Vaccinate everybody who's triple panel negative. Surface antigen positive, you're going to check Delta, you're going to check DNA, you're going to check surface antigen quant. You're going to treat all patients who are DNA positive with one of the nukes. Of course, you're going to stage liver disease and decide if they need liver cancer surveillance. Serious disease, and we've really summarized in the 5-line guideline. All right, let's go to Delta just for a minute. Delta is deadly. 70% chance of dying within 10 to 20 years if you have Delta D plus B. You can only have Delta if you have hepatitis B positive surface antigen. And Delta is in all sorts of strange places in the world. Mongolia is over 60%. There's also a few countries such as Iraq, which are highlighted here. In Central Africa, this is Central African Republic. And then in the upper Amazonia on the far left, you can see in South America, in Colombia and Venezuela, and also in the upper northwest part of Brazil, Delta is very, very common also. D is for deadly, high risk of liver cancer and cirrhosis, vaccine preventable. Interferon will manage Delta in 15 to 20% of people, but there's a new drug, new medication from Gilead, hopefully going to be approved in 2025 and available, called bulevirtide. Bulevirtide is a chronic treatment, but you can get 60% viral control with bulevirtide. And in the future, combining bulevirtide with interferon will probably result in cure rates in the up to 40% range. Combination therapy for Delta, I think, is just around the corner. All right, let's talk about hepatitis C. We've had this huge change in hepatitis C epidemiology from baby boomers to now this double bump that's on the right side, where there's a very high prevalence in women and men from active IV drug use. This is part of this fentanyl and narcotic addiction and high-risk behavior we have, where hepatitis C is a big problem, and limited access to drug because insurance companies and Medicaid programs decided to put up barriers to access this drug that has a cure rate of 98%. Test all adults for hepatitis C with antibody testing. You're going to test all pregnant women, of course, for hepatitis C as an add-on. Annual testing for hepatitis C would follow in anybody who's got high-risk behavior, including drug use or high-risk sex. But if somebody has hepatitis C antibody and they're having high-risk behavior, you need to check them with this RNA test, that PCR test, which is a partner to hepatitis C antibody testing. A lot of risk behavior can lead to hepatitis B and C. And that's why I have this very, very simple flow diagram. Antibody positive, you move on and get quantitative hepatitis C RNA. RNA is positive, those people need to go on treatment. We've got great treatments, either 8 weeks or 12 weeks, cure rates over 98%, very few side effects, very few drug-drug interactions. So hepatitis C, C is for chronic, but actually C is for cure. We don't do genotype testing. We don't do resistance testing. To get somebody on treatment, yes, we're going to give them substance use counseling, but we're not going to block access because they may be actively using drugs or alcohol. We're going to treat their mental health disorders as part of our multidisciplinary team to manage these patients. Just like with hepatitis B, everybody has to have staging. How much scar tissue do they have? Do they have cirrhosis? And of course, you're going to get HIV, hepatitis A, and B serology in somebody with hepatitis C. You've all heard about staging. Do you have cirrhosis or not? This is going from 0 to 4. 4 is cirrhosis. 0 is normal, no damage. So always ask your provider, what's my stage? Am I getting worse? Am I getting better? The staging issue does not require a biopsy. You're seeing biopsy pictures on this slide. But we don't biopsy patients with hepatitis C. We rarely biopsy patients with hepatitis B. This is because our non-invasive testing, just like for fatty liver, is quite accurate when done properly, of course. So we've got this rising epidemic of hepatitis C alongside hepatitis B, alongside rising overdose deaths. This is part of this fentanyl crisis in our country. The fentanyl crisis, of course, is a spinoff from the OxyContin and all the other problems we had in the last 2 decades. And also fentanyl is imported from China and also imported and made in Mexico. And it's super easy because this is 100 times more potent than heroin. So it's very easy to hide. Of course, people handling fentanyl have actually died just touching a box or touching a suitcase with fentanyl. There's been a problem at the border as these drugs are brought across from Mexico. So fentanyl is part of the problem, although recently fentanyl overdose deaths have fallen, potentially due to some risk management that's going on. So lots going on with hepatitis C. Every adult gets tested for hepatitis C antibody. Antibody positive, we check what's called PCR to quantitate the virus. The virus is positive, we go on and treat them. So we're harmonizing hepatitis C, treat everybody. HIV, we treat everybody. And now, with you following the new guidelines from WHO and what I call the Chinese guidelines, it's treat everybody. Super major advance, in my opinion. So this just was the New York Times squandering our great new hepatitis C drugs because of obstructions from the insurance companies. Huge, huge problem. This has to do with just how you manage a person with hepatitis C, and it really means monitoring them, giving them follow-up, treating if they have an alcohol problem, treating them if they have a drug addiction problem. If they've got fatty liver, you're going to treat their fatty liver as well. Just treat the whole patient. Super, super important. So rules for hepatitis C: test everybody and at-risk children, get RNA testing, stage everybody, treat everybody. Super important, of course, to manage them long-term. This is the cure rate, 98%. Hepatitis C, C for chronic, C for cure. Okay, we've covered everything on this slide. That was just a little bit summary. We're going to wrap things up with hepatitis E. E is for enteric, meaning it's fecal oral contaminated water. There's a very famous Armenian man who was working in Afghanistan who saw the Russian soldiers that were there who had invaded Afghanistan were getting jaundice and dying of liver failure. And he figured out this virus first by infecting himself, and then going to electron microscopy and following some other very special tools. So we've known about hepatitis E as in Edward, for over 40 years. People-to-people transmission is the most common, although rare that you're going to transmit this directly by touching somebody. It has to do with contaminated food and contaminated water. And there's also transmission of hepatitis E from animals. People have gotten hepatitis E from eating contaminated meat, like from wild boar sausage as an example. In Hong Kong, there were rats that were transmitting hepatitis E to humans. So there is animal to human, but it's mostly water, contaminated water transmission. It is vaccine preventable. If you go around the United States, you're going to find 20 to 40% of people have antibody to hepatitis E. Chronic disease is only in people who either have HIV or immune suppressed with organ transplant. And hepatitis E is highly fatal in pregnant women, where you can lose the mom and lose the baby. There is a medicine called ribavirin that you can use. So hepatitis A for acute, vaccine preventable. Test everybody, vaccinate everybody, in my opinion. Hepatitis B is for bad, but it's controllable with oral therapies. We have many new therapies coming for hepatitis B. Ask your doctor for a quantitative S antigen. If they don't know what to do with the quantitative S antigen, have them call me. Hepatitis C, test everybody. Everybody should be linked to care and treatment, just like with B, just like with HIV. Delta is for deadly. Every B patient should be checked for Delta. And hepatitis E, this is again E for enteric, can cause severe acute disease in adults, especially in pregnant women. And just be careful when you're traveling, wash your hands, make sure you're drinking, filtered or healthy water. And I think I'm on schedule, and I'll turn it back to my colleagues for next steps. Thanks again, Farah, for having me. Lori, thanks for your help.
Thank you, Dr. Gish. This was wonderful, wonderful. So much information. And as you were talking about it, that the hepatitis is a worldwide issue. So thank you for going through all the issues for us and bringing all the important points, especially about those who are preventable and have vaccine for, which a lot of people may not still know. Support, that's strange, they don't know. But thank you again. So now we're going to start the second half of the webinar, our roundtable discussion with our guest experts who will talk about their own experiences and research on hepatitis. It is my pleasure to welcome Dr. Edward Mena to our webinar. Dr. Mena is MD, FAASLD, MBA. He is the medical director of the Pasadena Liver Center, Director, California Liver Research Institute. After obtaining his undergraduate degree at UCLA and medical degree at USC, Dr. Mena completed his residency at White Memorial Medical Center, where he became the chief resident. Following this, he completed his fellowship in hepatology at USC Rancho Los Amigos Medical Center Liver Unit. Dr. Mena has been serving the Los Angeles community for over 20 years. During this time, he established a multidisciplinary center called the Pasadena Liver Center in 2007. He did that with fellow collaborators for the purpose of providing treatment options for patients with advanced liver disease. As the medical director of the Pasadena Liver Center, he coordinates all aspects of both inpatient and outpatient care. In addition, he has been instrumental in improving the treatment of liver diseases. He established a collaboration with the Cedars-Sinai and USC liver transplant teams that facilitate the management of liver cancer and liver treatment center for liver transplant cases. This revolutionary program created an outpatient treatment center for hepatocellular carcinoma patients, which is cancer, bringing together patients and doctors that provided a more efficient process of administering treatment. In 2006, Dr. Mena established a research institute called the California Liver Research Institute, or CLRI. This is a nonprofit organization focused on the advancement of treatment and curing of all forms of liver diseases. Since its inception, Dr. Mena has coordinated over 20 clinical trials. Under Dr. Mena's directorship, the Pasadena Liver Center and CLRI have become one of the busiest and the most successful liver centers in the Los Angeles area. In addition to overseeing both his clinic and research institute, Dr. Mena is a tireless advocate for the awareness of liver disease in the community. He coordinates awareness programs for the Latino and Asian community that encourage the screening of liver disease, such as fatty liver disease, cirrhosis, HCC, and hepatitis C and B. In 2019, Dr. Mena was awarded the Hispanic Health Leadership Award by the National Hispanic Health Foundation in recognition for his strong leadership in the health community. In 2020, Dr. Mena was awarded the Fellowship of the American Association for the Advancement of Liver Disease. In 2024, Liver Health Foundation was proud to honor Dr. Mena with Visionary Leadership Award for his groundbreaking work in Latino community and Asian community. Dr. Mena is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Mena, welcome, and thank you for your participation.
Thank you, Farah. That was a lovely, long introduction. You're the best. Thank you so much. And great slide presentation by Dr. Gish. Those are some great, great slides.
Yes, yes. We're going to be talking about that in a roundtable discussion soon. Now I am pleased to introduce the newest member of the Liver Health Foundation's Medical Advisory Council, Dr. Sean Shandena. He is a DO and FACP. He is the attending physician, Division of Gastroenterology, Department of Medicine, Olive View, UCLA Medical Center. He is a visiting associate professor, David Geffen School of Medicine at UCLA. Dr. Shandena earned his Bachelor of Science in Microbiology, Immunology, and Molecular Genetics at the University of California, LA. He received his medical degree with honors from Western University of Health Sciences. He completed his residency in internal medicine and dual fellowship in gastroenterology and transplant hepatology at the University of Cincinnati. Dr. Shandana is a highly experienced hepatologist with medical expertise in general and transplant hepatology. He has held faculty position at the University of Utah and the University of Cincinnati when he was assistant professor of medicine. He co-developed the multidisciplinary liver tumor clinic at the University of Utah Huntsman Cancer Institute and served as assistant fellowship director for gastroenterology at the University of Cincinnati. Dr. Shandana has been published in peer-reviewed research journals. He has been a principal investigator and sub-investigator for multiple clinical trials. He has served on the ethics committee for the American Association for the Study of Liver Diseases. He is a public policy subcommittee member for the American Society of Transplantation, Liver and Intestinal Community of Practice. He is a fellow of the American College of Physicians and is a board certified in internal medicine, gastroenterology, and transplant hepatology. He is also a member of the Liver Health Foundation's Medical Advisory Council. Welcome, Dr. Shandana. Thank you for your support.
Thank you so much, Farah, for the lovely introduction. And again, thank you, Bob, for an amazing slide set to talk about viral hepatitis.
To start the roundtable, I would like to ask a question that was repeated several times by people who have sent their questions in. The question is, what are the potential side effects of viral hepatitis treatment, whether it's a vaccine or medication? And how do these treatments impact other organs in the body? Dr. Gish, would you like to comment on this question?
We don't treat any of the virus infections we talked about today with vaccines. We use vaccines to prevent those, and the vaccines are phenomenally safe with a severe adverse event in maybe 1 in a million people. So that's good news. For hepatitis B, the oral medicines have a side effect profile that under 1 in 100 people has to stop for a headache or GI upset. Phenomenally safe. TDF, if you're on TDF for 3 to 5 years, there's an increased risk of bone disease and also kidney problems. That's why we tend to use entecavir, low price, or TAF, which is the best of the three in terms of viral suppression, normalizing ALT. So, and then once you get to hepatitis C, we have these oral medicines. Again, 1% have side effects. They might have to come off, but they're extremely safe. And these medicines don't hurt other organs other than I mentioned TDF, which might hurt kidney or bone. The hepatitis C medicines are so short that having some reaction other than allergic reactions rare. So we've got great vaccines. We have great medicines. We need to use them.
Oh, I think you went on mute.
Dr. Mena, would you like to add anything?
You know, I think, especially in today's society, I think we really need to echo what Bob just said, especially on the vaccines and how vaccines are very safe and well tolerated. They prevent disease, and it's a good thing to obtain the appropriate vaccines.
Dr. Chandana?
Yeah, I would echo very similarly that what Dr. Gish had mentioned. With anyone with chronic liver disease, we always like to assess their hepatitis A immunity status and their hepatitis B immunity status and try to help prevent them from preventable diseases. And so I think they are very safe, they are very effective. And even with regards to the medications, as Dr. Gish said, there's very little incidence of renal dysfunction or osteoporosis or bone weakening. I myself, have not really observed these effects even in my own patients. And so the incidence of them is, essentially less than 1%, if even. As Dr. Gish said, entecavir is very safe. Tenofovir alafenamide has less risk of renal dysfunction or bone issues compared to TDF. They are very safe medications, and vaccinations are definitely something that's encouraged for our patients as well.
That really works with the question that a nurse had sent to us and said, if diabetic patients are at low risk for Hep B infection, should I try to convince them to get vaccinated? And what are some good selling points? I
Mhm.
live in a string anti-vax area.
I find myself doing this all day, every day, trying to convince patients who have to get vaccines. And there's certain parts of LA County, Orange County that are just so. Now I think we're gonna call them anti-vaxxers, if you will. But I think if you have diabetes and other chronic illnesses, you should protect yourself from having certain diseases, and getting the vaccines is the right way to do it. And it's so simple now to get a vaccine, and you go to your local pharmacy and set up an appointment with I have my pharmacy at Vaughn's, and they send me a text when I need the next vaccine and when I'm due. So I just think it's safe. The side effects, like Bob said, are almost minimal to none. Wouldn't say zero of anything, but I think it's pretty safe and well tolerated.
My understanding is that the CDC has recommended that everybody get testing for hepatitis B, and that includes the triple panel that Dr. Gish mentioned, which is an S antigen, a core antibody, and also a surface antibody. And so with that, I would take it a step further and say not only, patients with comorbidities should certainly be vaccinated, those patients that have either liver disease, immunosuppression, metabolic diseases, as Dr. Mena was mentioning as well, but I would go so far as to say that really everybody should be vaccinated in today's world for hepatitis B. And Bob, you can certainly comment on that.
I just want to make a comment about the anti-vax world that's out there. And the sad thing about the anti-vax community is that people that spread the anti-vaccine message are making money off selling an anti-vax message. So yeah, the vaccine companies make money off selling vaccines, but the anti-vax people are making money just spreading rumors. And I've had 2 monkeypox, 9 coronavirus, been vaccinated for B, been vaccinated for A. I believe in these vaccines, and people come to me asking because they trust me, and then they say they don't want to take a vaccine. It just isn't logical. I think giving up vaccines is like giving up your plumbing in your house, and let's get rid of fire. People have been burned by fire, so let's get rid of fire too. Let's be logical. Vaccines were one of the greatest inventions in the history of the world and are extremely safe.
I'm also just going to comment that the vaccinations, depending on which vaccine series you get, is as little as a month. I mean, there's now a vaccination series, Heplisab B, it's 2 injections over 1 month. There's an Energix B series, which is 3 injections over 6 months. These vaccines are easy to take. Depending on what series you are getting, you could be literally done within a month.
Yeah, and it's, as you say, so easy. Our pharmacy let us know that it's time to get this vaccine or that vaccine. They keep record, and it's painless and easy, and you feel safe afterwards. So I hope that people hear your message, all of your messages. So we'll see what happens. This is a question, Dr. Gish. I think you have covered it, but I wonder if there is anything else you want to say about that. The question is, have there been any recent new developments in the treatment modality for viral hepatitis?
Yeah, I mean, just think about hepatitis C. 2013, we had highly toxic medicine that had a 50% cure rate. By 2015, you're taking 1 pill once a day for 84 days or 3 pills for 8 weeks, and cure rate's 98%. I don't think we're going to get any better than that. We have these 2 medicines for hepatitis C. There are some newer ones coming out that may be shorter treatments possible. Hepatitis B, we've got also medicines. The entecavir dates back 20 years. TDF dates back 18 years. TAF dates back 14 years. We have extremely effective medicine. But what's coming next for B is a functional cure rate, somewhere between 40 and 50%. I mean, it's a half of people will lose surface antigen with treatment of a year or less. We have many companies that are working in this space very aggressively. This includes GSK and Roche and Gilead, and then a lot of smaller companies are deep into this treatment paradigm for hepatitis B. We want to get to a functional cure. We want people off treatment. This reduces stigma, reduces discrimination, improves quality of life. There's so many benefits to treating everybody and eventually treating everybody for a functional cure.
I'd also like to add that also the importance of, it's just a great time in our history for research and clinical trials and participating in clinical trials. I think it's important, especially for us to reach out to members of our community who have these diseases to participate in clinical trials, because that's how we learn how these drugs are going to get a functional cure, how these drugs are going to work in our community and environment and improve quality of life, as Bob said. So I think it's important to educate our patients and community about clinical trials.
I would echo the same comments. That's how we advance science. And every time you look at the number of clinical trials in hepatitis B, there's, there's at least somewhere between 20 to 50 trials.
The next question is, how does blood tests indicate the severity of the viral hepatitis infection? Does it show the severity of it, or it just shows that somebody has the infection?
I'm not sure what you mean by stability, but maybe you mean chronicity.
Severity.
Oh, the severity.
Yes.
So that's measured by the liver enzymes and by liver function. So if you have liver enzymes that are over 1 or 200 with any of these viruses, that means very active disease. If it's over 500 or 1,000, then it's urgent to get on management right away. But watch liver function. The best liver function test is the bilirubin. And if the bilirubin is elevated, your provider should be ordering what's called a direct bilirubin. That's truly the best liver function test. So watch the bilirubin. That's really a flag that the liver's severely injured and it needs even more active treatment. Link with your provider for this.
I would also say that, not just in addition to blood tests, but also we now have newer technologies such as transient elastography, or, there are several different products out there. One of them is FibroScan, and there are others. But these are tests that will help us also evaluate the severity of disease by looking at the staging or the fibrosis, how much scarring there is. We've largely replaced the need for biopsies with doing these types of tests nowadays.
Dr. Mena?
Agreed. I'm a huge fan of transient elastography. I think it really helps guide us as to the severity of disease. And I sometimes like to use 2 or 3 what are called non-invasive testing, whether it's the transient elastography. There's a blood test to look for liver fibrosis called the ELF score. And I like to use at least 2 different or 3 different modalities to help guide me as to the severity of disease.
And I'll just throw back in there something that's very easy for patients to also remember, something called a FIB-4 score. This is something that's very easy that can be done by primary care providers. Patients can probably even look at their own labs and assess this online, but it's your age, AST, ALT, and platelets, and it's a great test to stratify our patients at high risk of a lot of scarring from things like hepatitis C. And so that is also important to remember.
So
I'd say the FIB-4 tells the truth 80% of the time, but 20% of the time it's not correct. So work with your provider to combine a lot of non-invasive tests. I look at 7 on every patient. I really just need 2 or 3 to get an accurate assessment.
Great, thank you. Dr. Gish, you talked about the sources of these various viruses. Does alcohol or smoking play any role, or is just really bodily contact and blood contact and other contamination?
Yeah, there's no transmission of any of these viruses by sharing a glass of wine or contaminated, alcohol in any way that I've ever heard of. So that's, so BCD, that's contaminated body fluids, and A&E is contaminated water, which means people have soiled the water in some way, what we call fecal soiling. So that's really the story. I think, did I answer that whole question, Farah? Or was there a part 2?
No, that was asking if smoking and alcohol.
Smoking. But smoking and alcohol makes liver disease worse in patients with chronic disease. So that's the big message. Smoking's never healthy. And for people with chronic liver disease, terrible. And if somebody has liver disease, they shouldn't be drinking alcohol, period. There's a lot of docs saying, oh, you can have 1 a month, you can have 1 a week. But when you tell them 1 a week, they have 1 a day. You tell them you have one a month, well, maybe they have one today. You know, there's like, they don't get the message that really it should be 0. And if you tell them 0, they'll probably get close to 0.
Yes. Dr. Mena, Dr. Chandana?
Just, you know, smoking is bad. Never recommend any smoking or tobacco products whatsoever. Zero tobacco, please.
Yeah, I'll just echo the statement. There's no safe limit for alcohol in any patient who has chronic liver disease.
And the question this gentleman has asked, how an infected person can avoid transmitting the virus to his or own family members and spouses? Do I need to be completely isolated from them?
I'll start with that one. So hepatitis B is transmitted by intimate contact. So you're not going to get it by shaking hands, hugging, kissing, sharing silverware, sharing dishes, sharing cups. So people with B and C should never be isolated. Now, if somebody has acute A or E, yes, they probably should be isolated for a few days or close to isolation. Washing hands and all other precautions would be there. But this is really a problem about discrimination against hepatitis B and C because of this false idea you're going to get it by being in the same room. It's a very sad part of, especially in Asia. It's even worse than the United States. In China, you can't get married. The Philippines, you can't get a job. The stigma around viral hepatitis is terrible. We need to stop the stigma.
Dr. Chandana, Dr. Mena, anything to add?
I think this just goes back to the, you know, as Bob said, I mean, you're not going to get it shaking hands or, you know, sharing glasses. But if you are intimate with your partner, it is important to have them tested for those respective diseases, hepatitis B, hepatitis C, you know, at least hepatitis B you can vaccinate for and prevent. And so that goes back to the importance of screening and vaccination when appropriate. And also using precautions if you're intimate with your partner in regards to hepatitis C, where there is, you know, no vaccination available for that.
And again, like we talked about earlier, if you have hepatitis C, our cure rates are just so 98%. So everyone with hepatitis C that's RNA positive should be treated for hepatitis C. And hepatitis B, here's where we talk about vaccines. All household contacts should be vaccinated.
And the other question is, please talk a little bit more about Hep E, why there is no vaccine for it in the United States still.
So that's a great question. There was a vaccine being developed by a company called Gene Labs in San Francisco on the peninsula. This is in the 1990s. I was actually working with them, but there's no money in the vaccine. So companies aren't going to invest in vaccine development unless there's a return on investment. And there was enough hepatitis E in China and also the ability to sell their vaccine in Bangladesh, India, Pakistan, other areas, or Afghanistan potentially, where hepatitis E was endemic. So that's the only vaccine. And another example is there was a really good hepatitis B vaccine that was just on the market in the US from a company called VBI. And that company has declared bankruptcy because they can't or didn't or were not able to make money off their vaccine and get their return on investment. So we just lost a very, very good vaccine for hepatitis B. I'm very sad about that. But vaccine development, it's a problem. And then we have this anti-vax community out there that really hurts vaccine development because of negative messaging. So we've got to work together. Vaccines are safe. They're incredibly good. The benefit far outweighs any risk. And that's really what the bottom line is.
Anything else, other doctors?
I think well said by Dr. Gish. And, you know, vaccine and vaccine development is important. And I hope we change a little bit in our thinking by certain groups. Really just stress the importance of vaccines and the good that they've done for people.
We have to keep talking about it and making sure everybody hears it. That's the only way I can see changing people's minds. I don't know if I'm pronouncing this correctly or not, but the question is, what is a fulminant hepatitis? Correct? Fulminant or fulminant? Fulminant? hepatitis, and when does it occur?
Sean, you going to take that one?
Yeah, I mean, I think this is referring more to fulminant liver failure, which certainly, there can be very rare cases of hepatitis A, and I even believe hepatitis E. Bob, you can probably correct me on that, of leading to fulminant liver failure. But fulminant liver failure is essentially when somebody has severe liver injury, their blood becomes very thin, they become jaundiced, and the development is that they develop confusion in somebody who typically does not have pre-existing liver disease. So I myself have seen a case of fulminant liver failure from hepatitis. I believe it was hepatitis A, if I'm not mistaken, but it was a long time back. It's very rare from hepatitis A and E. And then there used to be kind of in the transplant world after transplant, depending on hepatitis B or C, more commonly with C, some patients would get something called a fibrosing cholestatic hepatitis, which is a very severe rapid inflammation and scarring of their liver that essentially led to liver failure, but that is quite uncommon. And especially nowadays with these treatments, very easy to treat hepatitis C, even in somebody who got a transplanted liver that hadn't been treated prior. And then with hepatitis B, going back to suppression, these nucleotide drugs and entecavir tenofovir are just so effective at leading to suppression of virus that we really don't see these things nowadays.
I've seen fulminant hepatitis, fulminant hepatic failure from every one of the letters of the alphabet, but C, in my opinion, is the most rare. And the hepatitis E cases that I've seen have come into the US or were in contact with somebody who had traveled to one of these what we call low-income countries, underdeveloped countries. Hepatitis A, I've seen fulminant and people go to transplant, and hepatitis B in different settings. And of course, Delta, when you get it on top of B, or you get them as a co-infection, that can result in fulminant liver failure. But that's maybe showing my age that I've seen everything in this alphabet soup.
Dr. Mena?
I just wanted to comment
Yeah.
before Dr. Mena talks about it, because Bob, you reminded me of something very important, which is a concept of hepatitis B reactivation. So I have seen fulminant liver failure, both from, well, acute liver failure, essentially, from a case of reactivation a few times. And so it's important for patients to remember that if they've had prior exposure to hepatitis B, which can really only be tested by blood testing for these panels, and they get very severe immune suppression, there is a risk of reactivation. So patients need to talk to their doctors and say, hey, I am potentially going to be getting steroids. I am potentially going to be getting very strong immunosuppressive drugs. Am I at risk? That is something to remember.
Well said, and well said. And I also seen it, not so much a fulminant, but almost a very bad flare of hepatitis B when they're on treatment for Hep C. Remember when we treat Hep C and that have concomitant Hep B, that we should put them on an antiviral medication at the same time.
And the other question is, with will Hep C medication cure an already scarred liver?
Sarah didn't understand the question.
But the question was, will Hep C medication cure an already scarred liver?
Oh, I see. So I think the word is reversible, and I tend to use that more than a cure for scarring. But all the way up to people with early cirrhosis, we can reverse scarring, maybe 1, 2, sometimes 3 stages. So yes, scarring fibrosis can be reversed, provided people don't have advanced cirrhosis. I don't know, Edward and Sean, you think the same?
100%. I love saying the same thing, reversibility of disease. Even if they're early cirrhotic, we cure these patients and they get better. Only thing caveat I will say, if they do have cirrhosis, I always like to say they're married with me forever, and we like to do surveillance for liver cancer forever.
Ed just reminded me of the exact point that I was thinking, which is that patients who are diagnosed with cirrhosis, I mean, we may be able to reverse fibrosis by a few stages, but once you have really been diagnosed with cirrhosis, it would take a lot for us to not do screening. So the patients need to continue to get, I should say the word surveillance. Patients need to continue to get surveillance for liver cancer every 6 months.
I love that word, surveillance.
And I do want to also echo that hepatitis B is a virus that can cause liver cancer. And so in selected populations, Bob, you might want to comment on this further, but patients also in selected populations do need to continue to get screening for liver cancer every 6 months as well.
Wonderful. Our time is up, so I want to thank you so much, Dr. Mena, Dr. Chandana, Dr. Gish. Thank you so much for joining us. Dr. Mena, I know you're off duty today, and you still signed up to help us decipher this mystery of viral hepatitis. So I appreciate. We are thankful for our excellent guests who have agreed to support our programs. And I want to also make sure that everybody knows that our partners, our presenters, our volunteer physicians, they care deeply about liver patients, about you. They use their own time, their family time, to be here with us and help us understand liver disease and make people aware of the dangers of liver disease and what is the good way of living without hurting your liver. So my personal heartfelt appreciation to our doctors for your kindness and your support. Thank you, Dr. Gish, for your comprehensive presentation. We are grateful to have your support. Thank you for being a wonderful friend to the Liver Health Foundation over this last many years. Thank you again. Thank you, Dr. Mena. We look forward to working with you and your team in 2025 in Pasadena. Hopefully, we will help you and you will help us reach more liver patients and bring the word into Pasadena a little bit stronger.
Thank you.
Thank you, Dr. Chandana, for accepting our invitation and participating in this webinar. We hope to see you more at our events and programs in 2025.
Thank you.
Thank you. We thank our sponsor, GSK, for supporting this educational webinar. Liver Health Foundation will host another educational webinar on Alagille syndrome, a rare genetic disease that impacts children's hearts and livers. For more information and registration, please visit our website at liverhealthfoundations.org. Alagille syndrome webinar will be done in January 2025. We are on all social media sites. We have YouTubes of all of our webinars available on our website and our YouTube channel. We announce our events and programs and news on our website and social media, so please visit us. Once again, I want to thank you for joining us this evening for this important webinar. We appreciate our doctors and our sponsors. We wish you a very Merry Christmas and Happy Hanukkah. Be well, take care, and we will see you in 2025. Thank you.